Okay, this is the Cardiovascular Disorders chapter, and this is a pretty long lecture actually. Um, but just to, kind of review a little bit to talk about what the heart is and what it does. Yeah, it's a two-sided pump, and the left side of the heart pumps blood to the entire body. The right side pumps blood to the lungs and back. So the pressure in the left side is much higher than the pressure in the right side. Um, the innervation to the heart comes by way of the autonomic nervous system. The sympathetic effect is to speed up the heart. The vagus nerve is the parasympathetic connection, and the vagal tone keeps the heart rate between 60 and 80 beats per minute. So vagal tone is really important for controlling the regular rhythm of the heart. Also, the internal electrical conduction system is involved with autoarrhythmic cells, and these autoarrhythmic cells have a lower resting potential. And this system starts with the SA node, that is the pacemaker, and this is in the right atrium, and then that goes to the AV node, the AV bundle branches, Purkinje fibers, and that's all an electrical connection between cells within the heart itself. So that's just an overview, and like I said earlier, please take time to read the review section in the beginning of these chapters. It is important to read the textbook. This is one of those courses where you really need to read the material to get a better understanding and a picture of what's going on. And I'll try to walk you through it myself through some of the disorders that we're going to discuss with each chapter. So, looking at heart disorders, these types of disorders are a major cause of morbidity and mortality in North America. Common heart diseases are congenital heart defects, hypertensive heart diseases, angina and heart attacks, cardiac arrhythmias, and congestive heart failure. Diagnostic tests for cardiovascular function include ECG, which is the electrocardiogram. This is useful in initial diagnosis and monitoring arrhythmias, myocardial infarction, and pericarditis. Auscultation of heart sounds using a stethoscope to detect valvular abnormalities, or abnormal shunts of blood that occur, like heart murmurs. Exercise stress test, could be a bicycle, step, or a treadmill, assesses general cardiovascular function and in checking for exercise-induced problems such as arrhythmias. Chest x-ray films can show shape and size of the heart or evidence of pulmonary congestion associated with heart failure. There's nuclear imaging with radioactive thallium, assess the size of the infarct in the heart, extent of myocardial perfusion, and function of the ventricles. Cardiac catheterization, passing a catheter through a blood vessel into a ventricle can see inside the heart, and it measures pressures and assesses valve and heart function. Coronary angiopathy, blood flow can be visualized with this technique. You can see obstructions. They can be assessed and treated with catheterization and injected thrombolytic agents or laser therapy to break down clots, or balloon angioplasty to open a constricted artery. Blood tests. You can look at triglycerides, cholesterol, electrolytes, hemoglobin, hematocrit, blood cell counts, and differential counts for white blood cells. Arterial blood gas determination checks O2 sat, acid-base balance. This is looking at a stenosis observed during a coronary angiography, showing you the approximate location of the obstruction. General treatment for cardiac disorders, weight reduction, lower your fat in your diet, salt, Start an exercise program. Quit smoking. Smoking increases platelet adhesion and increases the risk of thrombus or clot formation. And sometimes drug therapy. And I did include some of the tables, but the tables are included in your book. Table 12.1 gives you a list of cardiovascular drugs that you might want to refer to, depending on the program you're involved in. But here's some of them here. There's 3 slides here that gives you name, use, action, adverse effect. And you can look through these. Some of these you may be familiar with. You may have family members that are on some of these for heart-related issues. Nitroglycerin, Lopressor, Lanoxin, Lasix to reduce fluid in people that have maybe congestive heart failure or fluid around the heart. Aspirin, warfarin is a commonly used anticoagulant. Zocor for cholesterol. So just you can familiarize yourself with this if you're going that route, and if you're going into nursing and programs where you're going to have to be familiar with medications. Okay, coronary artery disease, CAD, or ischemic heart disease, IHD. There are 2 terms that sound a lot alike, but they're entirely different. And the first one is arteriosclerosis, which is the general term for all types of arterial changes, degenerative changes common in older individuals and diabetics, commonly referred to as hardening of the arteries. Atherosclerosis is where you have the presence of atheromas or plaques consisting of lipids, cells, fibrin, and cellular debris, often with attached thrombi which form inside large arteries. And here's a picture that compares a normal aorta, to seeing how smooth the lining is, with an atherosclerotic aorta. And you can see where there are openings to the branches at the top, they're blocked at the bottom. This is a composition of lipoproteins and transport lipoproteins in the blood. Now, lipoproteins mean they're composed of lipids and proteins. And the higher the protein concentration, proteins are more dense than lipids. Lipids float in water, proteins will sink in water, so lipids are lighter, so they're less dense. And you can see at the top, HDLs are good lipids because they don't have the high cholesterol content that the LDLs do. LDLs, as a rule, they transport cholesterol from the liver to the tissue cells. And then there's something called VLDLs, very low density lipoproteins, that transport triglyceride from the liver to the body cells. HDLs tend to leave the liver empty, bring cholesterol and triglycerides back to the liver to be processed. So if you look at this this diagram here, the transport of lipids, dietary intake of cholesterol and triglycerides, which is a neutral fat and the primary source of fat, through the intestines are absorbed through chylomicrons into the blood and lymph, and through the lymph they go through structures called lacteals in the villi of the small intestine. And then the lipid is taken up by adipose and skeletal muscle cells. And then the remnants go to the liver, whatever's left over, and the liver is going to synthesize these lipoproteins. VLDLs transport triglycerides, LDLs transport cholesterol, and here's the LDL transporting cholesterol to the cells. The LDL attaches to LDL receptors in smooth muscle and endothelial tissues, and then HDL transport cholesterol from the cells to the liver. So that's the way this works. When you're talking about the development of an atheroma leading to arterial occlusion, there's usually a process involved where there's some kind of a damage that happens to the endothelium, which is the interior lining of an artery. And it's showing you on the top left-hand picture the tunics, or the layers of an artery. And so the tunica intima is the innermost layer, which contains the endothelium. That's simple squamous epithelium. The tunica media is the smooth muscle that's involved with vasoconstriction and vasodilation. And the adventitia is the outermost layer, which is usually a connective tissue layer that anchors that vessel to surrounding tissues. So the damage can really result in inflammation that causes a streak to be formed, sometimes connective tissue, sometimes fat deposits there, because rough edges will cause the fat to accumulate. And then as time goes on, this irritation here will result in inflammation, which draws in more immune cells. Platelets tend to adhere to this, and eventually, as time goes on, this increases in size through platelet aggregation. It causes a thrombus. Platelets, when they break down, release prostaglandins, and those prostaglandins cause more inflammation. The thrombus continues to grow, which results in this vicious cycle that draws in more and more platelets, more and more blood cells, and eventually the plaque may grow into an occlusion. It blocks off the vessel, or it could ulcerate or break and form an embolus that can travel downstream and block up smaller vessels along the path. So that's the development of an atheroma. Possible consequences of atherosclerosis. What can happen is, this is talking about the heart, the brain, peripheral arteries, but here's a clear artery, and if it is in the coronary arteries, which feed the heart, you can have a partial occlusion, which will reduce oxygen delivery to heart muscle, which can cause fleeting pain, or angina pectoris, which is diminished oxygen supply to the tissue and the heart muscle's not getting enough to perform the activity that you're engaged in, and so slowing down usually will solve the problem for the time being until it gets worse. Total occlusion or total blockage is called a myocardial infarction. And what happens here is that the cells downstream from the blockage are cut off completely from the oxygen supply, and they can die. If it's in the case of the brain, carotid or cerebral arteries that feed the brain, a partial occlusion can result in a TIA, transient ischemic attack, or a mini stroke. Total occlusion, cerebrovascular accident, or a complete stroke, and depending upon the extent of the blockage and how long the person is without oxygen will determine the effects of the stroke, whether it be temporary paralysis or total partial paralysis in a certain area. Some of it may come back over time, some may not. Medication usually is recommended to help prevent future strokes, but that's in the case of the brain. Now when you talk about the peripheral arteries, say the aorta, now that could produce an aneurysm, an occlusion, which could result in a rupture and hemorrhage. In the legs, iliac arteries, it can result in peripheral vascular disease. And if this is allowed to persist over time, tissue can die and result in gangrene and may involve something like amputation in severe situations. And this is looking at the difference: clear artery, partial obstruction, and total obstruction. So that's the consequences of atherosclerosis. Now the causes of atherosclerosis, factors that cannot be changed, more common after 40 years of age, especially in males. Gender, more common in males because women are protected by higher HDL levels until after menopause, when estrogen levels fall and drop. Genetic or familial factors relating that are relating to serum lipid levels. Some people just have, there's a disease, hypercholesterolemia, which is genetically determined. Also, metabolism and the number of cell receptors for lipids could be genetically predetermined as well. Modifiable factors: obesity or diets high in cholesterol and animal fat will increase lipid levels, especially LDLs. Cigarette smoking causes increases in LDLs and decreases in HDLs, which are the good ones, and promotes platelet adhesion. And fibrinogen, which is a clotting factor, also promotes vasoconstriction and clot formation. Sedentary lifestyle promotes sluggish blood flow and obesity. Exercise decreases blood pressure and stress and increases HDL levels and reduces LDL levels and cholesterol. Having diabetes increases lipid levels and vascular deterioration. Blood vessels tend to degenerate with diabetes. Poorly controlled hypertension. This causes endothelial damage, puts a lot of pressure on vessels, arteries especially. And a combination of some oral contraceptives and smoking can increase plaque formation. So treatment, diet modifications, lose weight, and if necessary, there are a number of lipid-reducing drugs called statins if you have to. Do your research before you get started on any of these. Reduce sodium to control high blood pressure. Control diabetes or hypertension. Stop smoking. In cases of thrombus formation, aspirin or Coumadin in these cases. Angioplasty may be recommended in advanced cases. This is a coronary artery bypass graph showing you how they go about this in some cases. This is a vein taken from a leg, and it bypasses, takes from the aorta and takes it below the point of the blockage. And the blood originally is going from the aorta to this part of the cell, this part of the heart here, and this bypasses the blockage completely. So it's a really nice way of restoring blood flow. And here, this is an artery bypass graft from the chest, and here's your blockage here. And so this coronary artery here has the blockage, and by taking it from here down beyond the blockage serves the purpose of bypassing that blockage. So that's generally what they do. Angina pectoris is chest pain that occurs when there is a deficit of oxygen for the heart muscle. Signs and symptoms: pain in the chest with pallor, diaphoresis, which means sweating, and nausea. Attacks vary in severity and last a few seconds or minutes. This is a look at what's going on when angina occurs. It's an imbalance between oxygen supply and demand. So here's the normal picture. The seesaw is balanced. Oxygen supply meets whatever the body is is doing at that time. If you increase the activity, you increase the oxygen, so we're still balanced. Now, in the case of myocardial ischemia, normal activity, oxygen levels don't increase, and so it doesn't meet the activity, so it results in pain. But if you decrease the activity, now the oxygen is sufficient to supply the needs of the body. Myocardial ischemia here, it gets to the point where eventually it doesn't even meet the basic needs. So when you get to the point that it gets very severe, then eventually something has to be done because you're not even able to do your daily activities. So that's the idea there. Emergency care for angina attack. Let the patient rest. Sit the patient upright. Administer nitroglycerin sublingually. Check pulse and respiration. Administer oxygen if necessary. If pain is longer than 5 minutes, give second dose of nitro, and after 3 doses within 10-minute period and no relief, treat as a myocardial infarction and call for assistance. If there's no history of angina, call for aid after 2 minutes with no relief. Myocardial infarction. This is where a coronary artery is totally obstructed, leading to prolonged ischemia and cell death, which is an infarction of the myocardium. Most common cause is atherosclerosis, which leads to a thrombus. Cell necrosis or cell death causes release of enzymes into tissue fluid and blood that can assist in the diagnosis. Signs and symptoms. Pain, sudden substernal chest pain that radiates to the left arm is classic, but may not necessarily be in that location. Usually severe, steady, and crushing with no release, even with rest or taking vasodilators. Pallor or sweating, nausea, dizziness, and weakness with dyspnea. Marked anxiety and fear. Hypotension is common and the pulse is rapid and weak as cardiac output decreases, and low-grade fever develops. This is a look at damage caused by myocardial infarction. So on the left, you see the area where the blockage is, and you see the purple area, which is where there's major cell death, and then this is the surrounding area where cells are possibly in the area of dying, and it's also an area of inflammation. And if you look at the picture, the cutaway section over here, you can see here the area of necrosis. Diagnostic test. ECG monitors changes and progress during both and after myocardial infarction. Serum enzymes and isoenzymes released from necrotic cells. Lactic dehydrogenase, LDH1, aspartate aminotransferase, AST, and creatinine phosphokinase with M and B subunits, CK&B or CPK2. These are all enzymes that are released from dead cells. Serum levels of myosin and troponin. Now, troponin is an early marker, and something that they found is a great marker within the first couple of hours to tell you how much cardiac damage is done. Serum electrolytes. Potassium and sodium may be abnormal. Leukocytosis, a lot more white blood cells come, drawn in by the inflammatory response, elevated C-reactive protein, CRP, and erythrosedimentation rate are common. CRP is a sensitive marker indicating a severe heart attack because it is an inflammatory marker that is secreted by the liver in cases of tissue injury. Arterial blood gases will be altered, particularly if shock is pronounced, and pulmonary artery pressure measurements are helpful in determining ventricular function. This is a look at the time lapse when these enzymes are actually evident in blood. And troponin, remember, shows up within several hours. That's not on this diagram. But usually 18 to 24 is CPK&B. AST shows up around 36 hours. And LDH shows up much later. So these are chemical enzymes that you would look for after a heart attack. Complications of MI. Arrhythmias. Sudden death occurs in 25% of cases. And another thing with myocardial infarctions, cocaine users may suffer fatal heart attacks because it interferes with cardiac conduction, also causing vasospasms and occlusion. Cardiogenic shock, diminished pumping action in left ventricle leads to reduced cardiac output, which causes greater hypoxia. Congestive heart failure. Rupture of necrotic tissue, especially with high blood pressure or ventricular aneurysm. Thromboembolism, caused by a dislodged blood clot from the damaged area. So these are all complications. And the treatment, rest, oxygen therapy, analgesics, sometimes morphine to treat pain, other morphine derivatives, anticoagulants, heparin or Coumadin, newer thrombolytic agents, streptokinase, urokinase, TPA, tissue plasminogen activator, administered immediately to break up clots before damage can occur or minimize damage. A pacemaker may be required if the patient is prone to arrhythmias. Digoxin helps support heart function. Other treatments if CHSF is a is a complication, sometimes bypass surgery. Cardiac arrhythmias. Dysrhythmias, alternations in cardiac rate or rhythm, may result from damage to heart's conduction system or electrolyte imbalances. Conduction system and its connection to the heart. This is just a review of what we talked about in A and P, but remember that the P wave is where the atria depolarize and the SA node starts the process, that's the pacemaker, and then you have contraction of the atria followed by the QRS, which is depolarization of the ventricles. Atrial repolarization occurs during that period of time, and then that's followed by ventricular contraction, and then the ending part, the T wave, is ventricular repolarization. So that's the conduction system through the heart. The cardiac cycle on average takes about 0.8 of a second, and that relates to 75 beats per minute. So cardiac arrhythmias, atrial conduction abnormalities, premature atrial contractions or beats, extra contractions of the atria, or ectopic beats of the atria. They interfere with the timing of the next beat. Sometimes people feel palpitations, which are rapid or irregular contractions that often arise from exercise. Sometimes caffeine intake, smoking, or stress can cause it. Atrial flutter is a rate of 160 to 350 beats per minute, and the AV node is delaying the conduction here. Atrial fibrillation is where you have a rate greater than 350 beats per minute, and at this point the heart's not really pumping blood anywhere, it's just quivering, the blood's sloshing around in the container, and if it's in the ventricles rather, you don't get any pumping action at all. Atrial fib is where you might pick up some palpitations. Cardiac arrhythmias, AV node abnormalities or heart blocks when the conduction is delayed or stopped at the AV node or bundle of His. Now there's three types. First degree, conduction delay prolongs the PR interval, and this is time between the atrial and ventricular contraction. So it's between the SA node and the AV node. Second degree, longer delay, can miss ventricle contractions periodically. So the QRS may be small or absent in this type of presentation. Third, which is no transmission of impulses from the atria to the ventricles. Ventricles can contract independent of atrial contraction, but only 35 to 45 beats per minute. Because you have to remember the way the heart is organized, the atria are the top chambers, and by gravity the blood will flow down into the ventricles, so you're not really dependent upon that pumping action of the atria for cardiac function, that the ventricles can contract on their own. Next up, ventricular conduction abnormalities. Bundle branch block. Interference with conduction in one of the bundle branches. This usually doesn't alter cardiac output, but appears on the ECG as a wide QRS wave. Ventricular tachycardia is likely to reduce cardiac output because filling time is reduced. Ventricular fibrillation, like I said earlier, the heart's quivering, not pumping the blood, and you have to treat this immediately because the cells of the body aren't getting their blood. Premature ventricular contractions, too many, cause fibrillation. But these are generally PVCs or additional beats. And sometimes in some people they occur occasionally, but they don't interfere with heart function. So it's just the amount of them that you have that will determine whether there's a problem or not. Treatment for cardiac arrhythmias. Beta-adrenergic blockers and calcium channel blockers, anti-arrhythmic drugs. Digoxin helps out with atrial dysrhythmias, slows the AV node conduction and strengthens contraction. Sometimes a pacemaker is needed for SA nodal problems or a total heart block And this is showing you a pacemaker and how a pacemaker is used. And actually, it can be on demand or one that works all the time. So it provides electrical stimulation through electrodes directly into the heart muscle, and, you know, works quite well. I know quite a few people that have these. Course of congestive heart failure. Now, we can maybe walk through this and kind of talk about it, but if you have a, say for example, myocardial infarction in the left ventricle and you have a loss of heart muscle, this is going to result in loss of strength with that muscle and decreased cardiac output. And the compensation mechanisms, so you're stimulating the sympathetic nervous system to have the heartbeat faster. So also vasoconstriction and increased resistance for left ventricle. Increased heart rate and force, this increased work for the heart. Stimulates renin secretion, which leads to activation of the angiotensin mechanism to cause vasoconstriction, which is also going to stimulate the adrenal cortex to release aldosterone, which increases sodium and water retention. This is all back to A&P. Increases blood volume, increases work for the heart. So over the course of time, this loss of cardiac muscle causes the heart to have to work harder. And over time, the left ventricle is going to weaken because those cells are working much harder than they normally would have to. And also the left ventricle does not fully empty, which decreases cardiac output. With increased blood pressure, you're putting a lot of back pressure on the aortic and the aortic semilunar valve, which means the heart has to work harder to open it, to push blood into the aorta. And then over time, the blood's going to back up into the pulmonary circulation, which results in pulmonary congestion, increased resistance for the right ventricle. The right ventricle weakens and cannot fully empty. Blood backs up in the systemic circulation, and edema in the legs and in digestive system. So left-sided, remember, is where you have backup in the pulmonary circulation, so you have edema there. Right-sided failure, backup is in the systemic circulation, and you see edema in the extremities. So the effect of CHF, what I just said, doesn't hurt to review it again. This is left-sided congestive heart failure. Left ventricle weakens and cannot empty. Decreased cardiac output to the system, so you don't get the blood out to the body. And then you have decreased renal flow, and remember, you actually filter through the kidneys 180 liters of fluid derived from plasma every day. So the renal artery is one of the largest arteries in the body. And if you're not getting circulation through there properly, then what happens is renin is released, and then that activates that angiotensin mechanism, which causes vasoconstriction, aldosterone secretion, and that is going to lead to a backup of blood into the pulmonary vein because the left ventricle is too weak. And so that leads to high pressure in the pulmonary capillaries, leads to pulmonary congestion and edema. And incidentally, people that have this condition, it's almost like they have a pneumonia. They develop fluid in the lungs, and many times they have to give them Lasix to remove the fluid. And it's one of the worst case scenarios as far as CHF, because if you cannot improve on the condition, a lot of times over time they will die. Now, right-sided congestive heart failure. Here you have the right ventricle that's weak and cannot empty. So decreased cardiac output to the system over time. This is going to affect the whole system. So decreased renal blood flow stimulates renin, angiotensin, and aldosterone secretion again. Backup of blood into the systemic circulation, so back into the vena cava, where it's coming from. Increased venous pressure results in edema in legs and liver and abdominal organs, and very high venous pressure causes distended neck vein and cerebral edema. So those are both problems associated with CHF depending upon which side of the heart we're talking about. Here's CHF and effects on the heart, and you can see enlarged left side of the heart there. So over time can really cause major problems. Treatment for CHF: reduce activity and stress. Dietary changes: reduce sodium, lower cholesterol, increase protein and iron in the diet. Take ACE inhibitors, can reduce renin secretion and reduce vasoconstriction. Digoxin improves cardiac efficiency. Hypertensives and vasodilators reduce blood pressure. Diuretics reduce sodium and fluid or water accumulation. So that ends CHF. Now we go to congenital heart defects. Congenital heart defects, these are developmental defects that arise during the first 8 weeks, generally, of embryonic life. Valvular defects interfere with the normal flow of blood. So there's 3 different types. There's stenosis, incompetent valves, and a prolapse valve. This is looking at the effects of heart valve defects. So here you have normal blood, normal valve, and the blood flows freely forward and there's no backflow. Stenosis, less blood flows through narrowed opening. There's no backflow here. But an incompetent valve, the blood flows freely forward, but it regurgitates because the valve doesn't close properly, and it's called a leaky valve. And then the effect of aortic stenosis: narrowing of aortic valve limits blood leaving the ventricle. So it's stiff, it won't open properly, and you can't get sufficient blood out of the left ventricle. And so you have left ventricular hypertrophy. The ventricle enlarges because it doesn't empty completely, and this decreases cardiac output, and also it backs up over time where you don't get complete atrial emptying into the aorta because it's not being emptied itself. So that's the effect of aortic stenosis. Septal defects: allowing mixing of oxygenated blood from the pulmonary circulation with unoxygenated blood from the systemic circulation. VSD is a ventricular septal defect, is the most common. Shunts are abnormalities in position or shape of the large vesicles. Most defects can be detected by the presence of heart murmurs, additional sounds picked up by a stethoscope. So this picture here is looking at different types of septal defects versus stenosis and something called tetralogy of Fallot, which is a condition where you have 4 different abnormalities of the heart. So this is where you have a ventricular septal defect. You can see the opening there, and because the blood is under higher pressure here, it shunts from left to right. Pulmonary stenosis, where you have a hardening of the pulmonary semilunar valve. You get less blood to the pulmonary artery. It causes enlargement of the right ventricular wall. That's pulmonary stenosis. And then this is tetralogy of Fallot. It's 4 different things. You have pulmonary stenosis coupled with ventricular septal defect, right ventricular hypertrophy caused by that problem, and then there's also dextroposition of the aorta over the ventricular septal defect. So that's tetralogy of Fallot. Sometimes you see that in babies. Valvular defects: this is showing you a replacement valve. This is a porcine valve replacement used to replace a defective human valve. And then this is a look at a thrombus obstructing a mechanical prosthetic heart valve on the bottom. Inflammation and infection of the heart. Now we move on to something called rheumatic fever and rheumatic heart disease. This is an autoimmune problem. It's an autoimmune response to strep infection, and usually It affects children 5 to 15 years of age. Inflammation of the heart can affect all or one of the layers. So you can have pericarditis, myocarditis, or endocarditis, depending upon whether it affects the pericardium, the myocardium, or the endocardium, and can affect joint, skin, and basal nuclei in the brain. And usually that's more common in girls. It causes involuntary jerky movement in the face, arms, and legs. And the treatment: penicillin, anti-inflammatory agents, aspirin, corticosteroids, prednisone. Valve replacement may be necessary in severe cases. So this is the development of rheumatic fever and rheumatic heart disease. It starts with a group A beta hemolytic strep infection. Antibodies to that cross over and attach to connective tissue, collagen, which is in high concentrations in connective tissue, and that causes an immune response that leads to inflammation of the heart and can be in joints, skin, and brain as well. And depending upon which part of the heart it affects, pericarditis will lead to effusion or fluid buildup. Endocarditis will affect the valves. Myocarditis affecting the heart cells can result in arrhythmias. And then if the damage is permanent, scar tissue develops, and you could have loss of valve function or arrhythmias, and this leads over time to rheumatic heart disease. So rheumatic heart disease, A shows you an acute rheumatic mitral valvulitis superimposed on rheumatic heart disease. You can see the inflamed, swollen appearance of that valve, which usually is a very, very thin, almost transparent tissue. And B, mitral stenosis with fibrous thickening and distortion of valve leaflets. You can see there how they are very fibrotic and much thicker than if you did the heart dissection or the sheep heart dissection in A and P. You'll know those valve flaps were very, very thin, very thin. So these are very thickened and very opaque, not transparent like you would expect. Number 2, infective endocarditis. Now, infective endocarditis, subacute, in which the defective heart valves are infected by organisms of low virulence. These are things that, something like a Streptococcus viridans, part of the normal flora of the mouth, and something that gets displaced, or it could be the acute type. Normal heart valves are attacked by highly virulent microbes, and the onset may mimic the flu. And an example of a highly virulent microorganism may be something like Staph aureus. Treatment: antimicrobial drugs for a minimum of 4 weeks. Pericarditis is an inflammation of the pericardium. Rough and swollen surfaces cause chest pain and what may be called a friction rub. Acute pericarditis may be secondary to open heart surgery, myocardial infarction, rheumatic fever, lupus, cancer, renal failure, trauma, or viral infection. Effusion, accumulation of fluid develops. Treatment: aspiration of the fluid and analysis to determine the underlying cause. And the effects of pericardial effusion is that when you have fluid that builds up in this space, it compresses the heart so the heart can't expand and fill up. And when that happens, now you start getting backups, back up into the systemic circulation, decreased blood flow to the lungs, and decreased output to the body. So overall, it reduces the overall functioning of the heart. Now we go to arterial diseases, vascular disorders. And we'll start with hypertension. Hypertension, there's actually 3 types, and the type that's most common, and makes up about 90% of all cases, is primary hypertension. The cause is idiopathic, no real unknown cause, but there are underlying risk factors. And this is blood pressure that's greater than 140/90. and it causes an increase in arterial vasoconstriction. Poorly controlled high blood pressure can lead to chronic renal failure and stroke due to hemorrhage, loss of vision, or congestive heart failure. Secondary usually is some type of a endocrine disorder, like Cushing's disease or pheochromocytoma, which is a benign tumor of the adrenal medulla gland. And remember, the adrenal medulla produces epinephrine and norepinephrine, which would increase the sympathetic response, fight or flight response, which one of the effects there is to increase blood pressure. Malignant is uncontrollable, severe, and rapidly progressive. Treatment is lifestyle changes. Change your diet, increase your exercise, reduce stress. Thiazide, diuretics, ACE inhibitors, alpha blockers to cause vasodilation, calcium blockers, and beta blockers to slow down the heart. Peripheral vascular disease and atherosclerosis. Now, PVD refers to any abnormality in the arteries or veins outside the heart. Atheromas are most common in the femoral, aorta, and iliac arteries. Loss of blood supply in the limb leads to necrosis, ulcers, and gangrene. You can assess the problem by ultrasonography and arteriography. Treatment for PVD: reduce serum cholesterol. Thrombus formation can be reduced by platelet inhibitors or anticoagulant meds, and quit smoking because smoking promotes platelet adhesion. Exercise program helps circulation. Calcium blockers, these are peripheral vasodilators. Surgery, maybe bypass grafts using a vein or a synthetic material. Angiography to reduce plaques. Angioplasty to reduce plaques. And endarterectomy, which is removal of the intima and obstructive material. Avoid skin trauma. Make sure shoes fit properly. Gangrenous ulcers can be treated with antibiotics and debridement and amputation if necessary to avoid spread of infection. Aortic aneurysm, a localized dilation in an arterial wall, common in abdominal or thoracic aorta. Many aneurysms eventually rupture, causing massive hemorrhage. 3 types of aneurysms. There's something called a saccular aneurysm, which is a bulging wall on one side. Fusiform, circumferential dilation along a section of the artery. Or a dissecting aneurysm, which comes from a tear in the intima, which will allow blood to flow along the vessel between the layers of the arterial wall. So this is showing you fusiform, saccular. There's a thrombus forming in that outpocketing, and here's a dissecting aneurysm, which shows a tear in the intima and blood flowing in between the layers of the wall. And here's dissected out a couple of aneurysms. Venous disorders, varicose veins. These are irregular, dilated, or tortuous areas of the superficial or deep veins, common in legs, esophagus, and rectum, known as hemorrhoids. Tend to be inherited as a weakness in the vein walls. Other factors: increased pressure in the legs, standing for long periods of time, crossing legs, wearing tight clothes, pregnancy. And this is showing you development of varicose veins. Here's an incompetent valve, dilated superficial vein, diversion of blood to communicating vein. Here's a normal one here with a normal venous valve, and you can see the walls are nice and smooth. And this is showing you how blood flows upward through an open valve as muscle contraction compresses the vein and forces the flow upward. Competent valve closed and prevents backflow. Incompetent or leaky valve permits blood to flow backwards in the vein, and then you get distension in the walls and sometimes these valve distortions are visible through the surface of the skin. Thrombophlebitis or phlebothrombosis, and the words sound very similar, except that phlebothrombosis is thrombosis without prior inflammation, and thrombophlebitis is a swelling of a vein caused by a blood clot that results in inflammation. So they're very closely related and sometimes used interchangeably. So it's a development of a clot in the vein caused by sluggish blood flow, endothelial injury, increased blood coagulability from dehydration, cancer, pregnancy, or increased platelet adhesion. Critical problem is that venous thrombus may lead to pulmonary embolism. And then the chapter ends up with types of hypotension caused by decrease in blood volume, and this is called shock. Types of shock, the first one is hypovolemic shock from a traumatic injury where you lose large amounts of blood. 2, cardiogenic shock from decreased ability of the heart to pump blood effectively, like we saw in congestive heart failure. C, neurogenic or vascular shock from fear or a spinal cord injury. 4, anaphylactic shock, which is a severe allergic reaction that causes rapid drop in blood pressure. And septic shock caused by some bacterial toxins. So those are types of cardiogenic shock. And that ends this very, very long chapter.